This video will discuss the treatment options for chronic pelvic pain for women and people assigned female at birth.
My treatment journey started with Advil, over double the maximum daily dose, supplemented with Tylenol. I moved on to stronger anti-inflammatories, eventually onto oral birth control, and finally had a cyst removal that resulted in a diagnosis of scar tissue, which was suspected to be endometriosis. I then continued on oral birth control, sometimes on continuous cycles so that I wouldn't get my period. And then eventually I had 3 more surgeries because the endometriosis just kept coming back. I kept experiencing widespread chronic pelvic pain, and I ended up having a total hysterectomy combined with a bowel surgery to remove lesions and then to remove my uterus, fallopian tubes, cervix, and ovaries. Most of the time, a doctor would say, well, this should be helping. And I wouldn't understand what I was supposed to do with that because it would put me back in a position to not be believed when it wasn't helping. And very seldom would a doctor say, okay, this clearly isn't helping, let's look for something. I am curious about what we can do to engage in this together. It was just try this, see you in 6 months, try this, hopefully it will work. So it really made me feel like I was failing as a patient when it didn't help or it didn't work. A GP's responsibility is also to take a look at holistically who you're seeing, what specialists you're seeing, what diagnoses are being made, and connect them all so that it's not a disparate, this is happening here and that's happening there, and nobody's taking a look at the whole picture and connecting all of those things together. Even though the diagnosis was crucial to understanding what was going on, I don't think that there was enough education about what pain management really looks like for people and how to create a nuanced and holistic approach to pain management for patients that doesn't just leave them taking the responsibility all on themselves, and that also allows them to feel like it's okay if they're still in pain and that they can tell you and you're going to find a way to work with them through that.
The treatment of chronic pelvic pain requires a comprehensive and multimodal approach. A patient-centered management plan should be actively developed with a person experiencing chronic pelvic pain that depends on the underlying etiology and considers the person's social, economic, and geographical status and goals for care. This approach will help to decrease disability by aiming to improve emotional, physical, and social functioning rather than focusing strictly on pain reduction.
For me, patient-centered means listening to what I have to say, not rushing me out because you've overscheduled your appointments. It means really hearing what I have to say and helping me come up with solutions besides the pill. By being able to say to me, try these different techniques, try the mindfulness. For me, means you see the person as a whole person. It's not just the pain I'm feeling, but the effect on my body and my mind. I think it's really important for healthcare providers to really consider culture and the fact that, someone from my culture might not be as open and has had someone to actually discuss these things with. It might take a little bit more probing. It might take a little bit different language. It might take time, like you can't do it in 5 minutes. This is a longer conversation.
This is how it's affecting my life on a social level, on a financial level, on a personal level. How can we manage each of these things? You don't often think about those things when you think about going to the doctor, but they are essential in taking a wider look at how pain is causing a lasting effect on someone's life and what maybe the priorities for treating it and diagnosing it would be.
Organ-specific contributors should be considered. Other treatments should address the psychosocial aspects of pain and central sensitization.
I think treating chronic pelvic pain requires a 3-tiered approach. You need to treat the pain, which is the initial thing that usually is going to bring a patient in. You need to treat the underlying cause, which requires a curiosity about what's causing the pain, why Is it bigger than you think? And then you need to treat the effects of the condition on the patient's quality of life, which may involve holistic practices, lifestyle changes, emotional support, counseling, all manner of things. And if those 3 areas are being looked at and run with as a whole, the entirety of treatment for this kind of thing could open up in a way that would support patients like me.
There are a variety of different treatment options for chronic pelvic pain. The following treatment options will be discussed: lifestyle interventions and allied health, pharmacologic interventions, targeted treatments, and injection therapy treatments. Lifestyle interventions and allied health include pain neuroscience education, health behavior changes, physiotherapy, and psychological treatments. Pain neuroscience education helps patients redefine chronic pain. This biopsychosocial method can also reduce patient stress and anxiety related to their pain. This education covers how the brain and nervous system play a role in the experience of pain. You as the healthcare provider can be the one providing pain neuroscience education, or you can share resources for the patient to look into.
I don't think any of the GPs that I saw had brought up pain neuroscience education. I think in that vein, it often was, oh, it's probably anxiety or you have a low pain tolerance. Nothing about the science of pain or the effects of pain on the brain. And I think that education piece would have been very helpful younger, not just for treatment, but for the emotional toll that being in that kind of pain takes on you. When thinking about talking to patients about pain neuroscience education, thinking through the concept and how to explain it to a patient is essential, because it could easily come across as, your brain feels this, it's not real. And doing that in tandem with validating pain and validating the experience of pain is essential to then link those 2 together and say, this actually explains even more about why you continue to feel pain. It makes it, just as real or just another facet. Even after my hysterectomy, I did experience and still do experience a lot of central sensitization pain, and people still don't quite know what to make of that. But the things that I do for myself include mindfulness, counseling. I've been seeing a therapist about it. I still continue to take pain management as needed. Physical therapy, physiotherapy, and pelvic floor therapy are essential tools in managing central sensitization for me personally. Even when I'm experiencing a flare-up, understanding that my pain might be connected to central sensitization is helpful because it changes the way that I feel about treating it. Do I need to treat the root cause, or is this something that's connected more to the brain pain link that I'm experiencing?
There are health behavior changes that may help manage chronic pain. These include dietary modifications or the low FODMAP diet specific to IBS or IC diet for painful bladder syndrome. Exercise has shown to have some benefit for pain severity in chronic pain and cutting out smoking. In addition, relaxation techniques such as a warm bath for 20 minutes every day, meditation and mindfulness, yoga, and massages may be helpful tools to manage chronic pelvic pain.
There have been a number of tools that I have used to help me deal with my pelvic pain that don't include a painkiller. I've done things like meditation, and that includes things like visualization, and that has helped a lot. I do yoga. That was something that was also done at the pelvic pain clinic. I used to get energy healings, acupuncture, taking baths for pleasure and not for the pain. Having things to look forward to, having connection. I think all of those things are related.
Physiotherapy treatments for pelvic pain include pelvic floor physio. This includes internal and external techniques applied to the pelvic floor and surrounding myofascial structures and at-home exercises. This has a high level of evidence in reducing pain. Psychological treatment for chronic pelvic pain may include cognitive behavioral therapy, acceptance and commitment therapy, and mindfulness meditation. This treatment is effective in reducing pain, ruminating, helplessness, and magnifying, as well as improving mood. Pharmacologic interventions include NSAIDs and neuromodulators. Opioid medications are not recommended for long-term management of chronic pelvic pain. However, for short-term acute pain crises, opioid medications might be helpful to de-escalate a pain crisis. NSAIDs can reduce pelvic pain, including dysmenorrhea. This treatment inhibits the enzyme cyclooxygenase, which then inhibits the formation of prostaglandins, which are involved in inflammation, pain, and uterine contractions. Neuromodulators may be helpful for chronic pelvic pain. Examples of neuromodulators are SNRIs, gabapentinoids, and tricyclics. Targeted treatments include hormonal medication or surgery for gynecologic contributors and treatment of comorbidities and underlying causes. Gynecologic contributors to chronic pelvic pain, like primary dysmenorrhea, endometriosis, or adenomyosis, can be managed by suppressing the menstrual cycle. Hormonal treatments may include combined progestin-estrogen contraceptives, progestins, gonadotropin-releasing hormone antagonists, and gonadotropin-releasing hormone agonists. These treatments reduce pain symptoms in people who experience pain exacerbation during their menstrual cycle, alongside chronic pelvic pain. Surgery could be considered to treat peripheral cause of pain, such as endometriosis, by surgical excision of lesions, but people with central sensitization nociplastic pain and/or other pain generators may still experience persistent pain after surgery. Surgery should be used with caution. If comorbidities have been diagnosed, such as painful bladder syndrome, interstitial cystitis, and irritable bowel syndrome, then an appropriate referral should be made to initiate appropriate treatment.
Injection therapies include trigger point injections, nerve blocks, and botulinum toxin injections.
Trigger point injections can be used to manage myofascial trigger points. The injections of local anesthetic reduce pain transmission from hyperactive nerves and provide pain relief as a result. Nerve blocks prevent pain transmission to the brain by blocking cell permeability to sodium, which normally leads to nerve cell transmission. Botulinum toxin injection inhibits the release of acetylcholine, which results in muscle relaxation. In the case of chronic pelvic pain, it can interrupt persistent muscle contractions. It also blocks other neurotransmitters that regulate pain, which add to its analgesic effect. Other treatment options include acupuncture. However, more research is required on its use for chronic pelvic pain. Multidisciplinary care may include support from pelvic physiotherapists, psychologists/counselors, gynecologists, dietitians, urologists, gastroenterologists, as well as pain clinics for chronic pelvic pain care. A combination of the treatments discussed in this video should be considered when treating chronic pelvic pain due to its complex nature.
I feel that you can't talk about physical pain without talking about the mental pain that goes along with it. I think that a lot of times it gets ignored. People look at your pain in isolation for what it is and don't make that connection. But I think the body-mind connection is so important, and I would love for practitioners to be aware of the different techniques that people can use, or different options that are available in their communities that they can access.
At the center of multidisciplinary treatment plans should be the patient and their expectations and values. Consider talking to your patient about their external health coverage to see what treatment options are accessible and affordable to them. Be transparent and honest about your thought process for possible treatments to reduce frustration and stress to patients. You should openly discuss the risks of treatments with patients as well.
The three most powerful words in treating a patient are "I don't know." I so desperately wish that some of my providers would have said, "I don't know what's going on, but it's okay because we're gonna find out," and to let me have agency in that decision making. It would have been helpful to hear multiple treatment options. Sometimes I would hear them, but it was often very heavily swayed to whatever the GP's opinion of a certain drug was or a certain treatment. I think often a practitioner is excited to say, "We found a diagnosis, this is definitely what it is." And that does shut a door for future treatment or even for expansion of the condition. And a lot of times I would get, "Oh, you have dysmenorrhea, which is, bad period pain." And that's what the diagnosis is. And I would think, okay, that's what it is. And then I would go away and there would be other things and it wouldn't include that. And I felt like I was doing something wrong by asking them to reopen it. And something that I think practitioners could do that would be really useful is to say, here's the information. We're going to schedule a follow-up in a week or two when you've had time to digest and ask the questions you need and write them down, and then you can come back and we'll talk about them, rather than we're deciding now or it's now or never, which is often what was said to me. I was asked to write a letter saying I would never regret having my surgery to remove my uterus before having it, and that's just not something a patient could ever know, and that was a requirement for me to do before I was even allowed to have the surgery.
If you tell me that you want me to take something, I want to know why. I want to know the how. And I feel a lot of times when I've gone to doctors and I said, okay, you want to put me on this new treatment, how does it work and why are we doing this instead of that? I find doctors are quick to give solutions or medications, but they don't talk about the risk factor. It is really important for doctors to discuss risk with their patients before prescribing treatment. We need to know what the upside and the downside is so that as a patient, we can make informed decisions.
I also think that sometimes the hormones that are prescribed, I've tried many, have emotional effects that you don't expect. And there were times where I had to stop taking something because it would put me into a really dark place. And I assumed that was why, because that was the variable, but nobody prepared me for that. So there's a mental health toll pharmacologically as well that I didn't expect.
Early treatment and intervention of pelvic pain could prevent people from transitioning into chronic persistent pain. After a treatment plan is initiated, a follow-up appointment should be done to assess whether the treatments attempted have met the person's goals for care, empower the person to take an active role in their treatment plan, and provide additional care recommendations if needed. There are instances where a primary care clinician may need to refer their patient dealing with chronic pelvic pain to another healthcare provider. Some examples of when you should refer to a specialist are when the patient comes back for repeated emergency visits for pain, despite initial unsuccessful treatment attempts, when all indicated tests come back negative and medical treatment has been unsuccessful in alleviating pain, when tests come back positive for a disease you do not have the expertise to manage, or a disease that requires treatments you cannot provide, such as surgery.
My GPs often wanted to push it onto someone else's plate, and yet didn't know where to refer me or who could take that on or how to kind of take the next step. I think I should have been referred to an OB before I was 16, and I wasn't until I was in my mid-20s. And that was only through the emergency room, not through a GP or a baseline medical provider. If you don't know, looping in someone else that can help is essential, and it should always be on the table to cast a wide net. Because referrals can take so long, a pain management strategy is essential. What to do on a daily level, how to navigate flare-ups, what kind of a crisis point plan is with a patient. It would be wonderful if a GP said, okay, here are the things that you experience at the levels of your pain, and here's how we can deal with each of them as they happen so that you're prepared if something kind of gets out of hand. And then also to keep checking in. Oftentimes a practitioner will order a referral and then you just won't hear from them for a year and you wonder if it's even been lost in the mail, So to follow up and do check-ins and say, hey, let's talk. Do we need to adjust anything? Do you have any questions? Has anything changed while you're waiting, so that the referral can be updated if need be? I think when creating a referral plan, it's a good idea to see what the capacity of the patient is, how much they're willing or able to take on, because chasing down a diagnosis and a treatment plan is a full-time job that people underestimate. You're dealing with pain in your everyday life, and then you're also trying to find out the why, navigating multiple people. For me, I prefer a widespread approach. I would have taken every appointment they would have given me, but not everybody's the same. So looping a patient in and saying, what can you handle and where are the first places we should go, or how many do we want to check out, would would be a way to engage a patient in their own care and give them agency.
I think it's important for people to know that the pain is real, it's debilitating, that there are ways to manage it, but we need your help and we need you to listen and help us do a plan together, something that's workable, something that is easy for healthcare practitioners to monitor, but also something that, like someone like me, that I can actually do, which is within my resources, which is within my ability to actually do. I think it's really important to see the patient as a whole person in partnership, and also to recognize the impacts of mental health on physical health.
In summary, a combination of therapies should be considered in the treatment of chronic pelvic pain, depending on the underlying pain contributors. Communicating the treatment plan with patients can reduce overall stress and frustration and help to keep the pain management plan in line with patient beliefs and values. Thank you for taking the time to watch this video on the treatment of chronic pelvic pain.